Good afternoon and welcome to today's webinar, IH and OEM, Optimizing Collaboration Amidst the COVID-19 Pandemic. My name is Heather Hodge and I'm with the American College of Occupational and Environmental Medicine. If you are not familiar with ACOEM and AIHA, ACOEM is a membership organization that promotes the health and safety of workers, workplaces, and environments through education, research, and development of public policy and advancing the field of occupational health. AIHA supports their members with expertise, networks, comprehensive education programs, and other products and services that help them maintain the highest professional and competency standards. Before we get started, just a reminder that we are recording today's session and will email the link to all registrants. We are delighted to have Dr. Gretchen Guzek, Dr. Rachel Leibu, Dr. Sara Pasqualoni, and Dina Siegel with us as faculty today. Dr. Guzek is a staff physician in workforce health and safety at the Columbia University Irving Medical Center campus of New York-Presbyterian Hospital. In addition to providing direct patient care, she works with the Workforce Health and Safety Medical Director and other departments regarding policy and procedure development and compliance processes. Dr. Rachel Leibu is currently the Medical Director of Occupational Medicine Services and Corporate Health for Atlantic Health System. Her interest in occupational medicine began after nursing school when she received a master's degree in industrial hygiene. She has worked in many different areas of occupational health and safety, including industrial hygiene, and is the editor of ECRI's Hospital Hazardous Materials Management newsletter. After medical school, she trained in internal medicine and occupational medicine and began working at Atlantic Health System as an occupational medicine physician. Over the past 9 months, she has worked extensively with COVID-related matters affecting employees, particularly those in the healthcare industry. Dr. Sara Pasqualoni is the medical director of Los Alamos National Laboratory and is co-chair of the Pandemic Advisor Team that works with the Emergency Operations Center to provide recommendations to senior laboratory, federal, and contractor leadership. She came to Los Alamos to start the hospitalist program at Los Alamos Medical Center. She always held an interest in preventive care, well-being, and public health, and welcomed the opportunity to transition from hospital care to occupational medicine at the lab in 2011. She stepped up to the medical director position in 2014 and completed her master's in public health degree through UC Berkeley in January of 2019. Ms. Dina Siegel has been practicing industrial hygiene and biological safety for over 30 years. She has a BS in environmental health and an MS in environmental science and is a certified industrial hygienist, certified safety professional, certified biosafety professional, and is an AIHA fellow. She currently provides program management, technical expertise, and continuous improvement in chemical safety, biosafety, and glove box safety at Los Alamos National Laboratory. Her current expertise also includes exposure assessment, nanotechnology, and chemical management. She has general expertise in the broad spectrum of IH programs for DOE, DOD, and private industry. Her last 8 months have been packed with COVID-related issues as the biosafety officer, industrial hygienist, charged with ensuring COVID-19 worker safety and protection at Los Alamos National Laboratory and as part of the laboratory's COVID task force. We are so delighted that you are all able to join us today, and we're looking forward to another fantastic webinar. I'll turn it over to Ms. Siegel now.
Thank you, Heather. I appreciate being invited to this, and I know we're going to have a great time today. So as we know, this has been a constantly evolving situation for all of us, both personally and professionally. As an industrial hygienist, I've learned new skills, applying the principles of industrial hygiene to the workplace and public COVID-19 issues that we face. So even today, we're working hard to protect our workers. We're also looking at additional strategies to protect our workers. Our New Mexico positivity rates have soared within the last 2 weeks, much like the rest of the nation. LANL is considered an essential business in the state of New Mexico, and as such, we are employing all possible strategies to get our work done safely with the lowest risk possible to our employees. We use information that we get from DOE, New Mexico Department of Health, CDC, AIHA, of course, ACOEM, We also have on-site modelers and biological research scientists that assist us as well. It is literally a daily changing landscape. Even since we prepared this talk, we've been evaluating some additional protections and strategies for the laboratory and providing those recommendations to our senior leadership, our senior leaders here at LANL. Sara, would you like to give a brief introduction?
Sure, Dina, thanks. So Dina really nicely addressed the challenges that are related to the dynamic nature of this pandemic, supporting a diverse workforce with diverse work scope, and the importance of being humble and agile as we continue to learn more about how SARS-CoV-2 behaves, about its transmission, and about the efficacy or inefficacy of different control measures. In the spirit of collaboration, however, I would also offer that just as important as how we support our leadership and how we take care of our workers is how we, as health and safety professionals, take care of ourselves and take care of each other. While I value having Dina available as a professional colleague to share ideas and concepts with, and as someone who shares articles and official positions from reputable sources with me, what I value most is our relationship. With the stress related to effectively navigating this ever-changing pandemic and protecting our employees and our community, Dina has been my stalwart companion and supporter, and I could not do this without her.
Thank you, Sara. I really appreciate that. Next slide, please. So let's get into this. I know everybody knows this, but I'm just going to give everybody a quick reminder of the COVID-19 timeline. So on January 1st of 20, the WHO announced the mysterious coronavirus-related pneumonia in Wuhan. CDC's first U.S. case was confirmed on January 21st. The global health emergency was issued on the 31st of January, when LANL also activated their pandemic advisory team. Global air travel was restricted starting in February. We declared the public health emergency in February. It was declared a pandemic in March. And then from a Los Alamos National Laboratory standpoint, which I'll now refer to as LANL, because we are great at acronyms here. At the end of March, we had our first confirmed case. We established the hotline. We implemented teleworking as a default. Our New Mexico schools closed. Some of them, at least the schools up here, have now gone to at least a hybrid model for the short term. And then we had the EOC, our Emergency Operations Center, and our COOP, our continuing ops, activated on March 9th. Next slide. So we have what we call our COVID-19 hub here at Los Alamos, and the top banner is displayed across our homepage, and then you can click on any one of these things to get further information. I'm going to talk today about the resources for on-site work, but we also tell people how to telework. We have FAQs, how to charge your time, what our current travel guidelines are based on DOE, the state, and the laboratory itself, our positive case count, and then the signs you can use. Next slide. So this is a slide that just kind of tells you how we were trying to develop a rational approach to bring our workers back on site. We actually did start out with a reduced mission to just critical operations. Right now, we are actually at normal operations with maximized telework. And you can see how this all fits together if you look at how we talk about our operating status description. We gave manager guidance that continues to be updated. We have policies and procedures that I will briefly talk about. And then when employees do come back to work on site, what they need to do and how they need to work. Next slide. So really, for Sara and I, it's about ensuring the safety of our workforce. So there's a wonderful picture of you there, Sara. We're also looking at the other things that we did in terms of activating our EOC and the COOP, creating our COVID-19 hotline, which is a 24/7 hotline staffed by our individuals here. One of the things that went was very quick was going from more than 12,000 on site to over 10,000 of those suddenly teleworking. We do on-site testing. We'll talk about our COVID response, cleaning response team, and then the hotline. Next slide. So one of the things that we really do very well here, if I may say so, is early case identification and containment. We do PCR testing here. This is a picture of our occupational medicine facility based on the risk and the potential impact on mission essential work. We also can have tests requested for special circumstances, and then we have a CLIA certified laboratory on site, which has been just wonderful, amazing, and amazing people to work with. So they are some of our researchers here that happen to also be CLIA certified, so we were able to stand that up fairly quickly. Next slide. We're also supporting, as a laboratory, community and public health efforts. We have a special office for COVID-19. We do modeling. We provide laboratory testing operations, as I just talked about. We apply AI and machine learning to some of the COVID problems. We provide medical countermeasures, and we are doing high-performance computing as part of that. Next slide. So we have several processes and procedures that we have used from the onset to the present. We have developed control strategies. We have a decision tree for cleaning and disinfecting, and we do contact tracing. We have worker communications, and then we continue to refine those based on our lessons learned. Next slide. So we have really five main written procedures that we use to as control strategies for our essential workers working on site. And the first one is our policy document, which is really our overriding document that talks to all of the things that we've put in place. We also have what we call quick take guides, which are really the specific control strategies that come out of the Occupational Safety and Health Division. Next slide. So the policy talks about that operational status, a phased approach, what we expect people to do before they come on site. We have a web-based training that we ask them to take. The responsible line managers have to re-review the work in consideration of the protocols that we have in place. And then everybody does a daily self-assessment every time they come on site. And then if they are working on site, isolating if feeling ill, having the social distancing, and putting the other quick take control strategies into place. Next slide. We also have travel requirements, how we respond to a confirmed COVID-19 case, and then other information that's helpful for everybody, where you get cleaning supplies, where you get PPE. We have fines we'll talk about, and then the work planning and control for on-site activities. So people are trying to basically do work while they're here, and there are deliverables, there are important things that they're trying to do, and we're asking them to do that all with our COVID control strategies in place. The roles and responsibilities of everybody as well are in this policy. Next slide. So we have a pre-job brief that we ask everybody to do, and pre-job brief is something we do here as part of our work management approach. And we really just want everybody not to redo their work processes and procedures, but to integrate the COVID-19 information into that and make adjustments where necessary. So following our New Mexico Department of Health guidelines, staying home is sick, which we say over and over and over again, completing the self-assessment, using the buddy system to hold each other accountable, and then what everybody I know is used to, which is don't touch your face and wash your hands and use hand sanitizer. Next slide. We also ask people to remind people, minimize their time within 6 feet, wear either one of our face masks or covering that meet certain criteria, and then making sure that that they, when they're eating, that they're maintaining that 6-foot distancing, and really wearing that mask at all times unless they're alone in their office or they're actively eating or drinking. Using their own tools, cleaning and disinfecting shared surfaces. And then because we work in radiological, biological, or chemical environments, making sure that that face mask or covering is removed and disposed of as contaminated clothing. Next slide. We also have, and I'm sure you guys are all familiar with this, there's nothing new in here that you haven't seen already. So we give instructions for cleaning work areas, which you'll see on this slide. Next slide. And then making sure that people are disinfecting their personal office spaces with a focus on the EPA list N. Next slide. We also have quick take guides on cleaning and disinfection of PPE. We tell people what to do with single-use gloves. If you're in biological or medical fields, you know what you do with a nitrile glove, but we have people that aren't necessarily familiar with that, so we make sure that they do that. And then we also give them requirements for reusable gloves, so if they're using a cryogen glove or things like that. Next slide. Also for our eyewear, again, just cleaning and disinfection of how to do that. Next slide. Also for, we have single-use LANL issued work clothing that's disposed of. If it's reusable, so I have a picture here of a welding, a leather, leathers for welding, and then telling people how to launder their personal clothing. So that's all part of our guidance. Next slide. And then for face masks and coverings, we have some pretty detailed requirements for this. Just so everybody knows, we look at face masks or coverings as a control strategy for COVID. We are differentiating that between actual respiratory protection that is either used as respiratory protection for biological or for other contaminants on site. So we give those requirements as well. Next slide. On respirators, this is how we clean respirators anyway, so respiratory protection goes through our usual approach. Next slide. Tools and equipment, we're really encouraging people not to share tools and equipment, and if they do, then wiping them down. So this is something that's pretty simple and pretty obvious, but we want to just make sure people understand that and do that. Next slide. So the other thing is just making sure that people get it in really more than one way and more than one place to practice social distancing, do all of these things that we're asking people to do. And that's kind of our overall control strategy. Next slide. We also, if there are times when people have to be less than 6 feet away, sometimes that's from another safety issue. But we're really asking people, if you're doing that, then we implement a health check, which is a verbal screening and a temperature check. We ask them to wear face and eye protection in addition to the mask or face covering, and then only really wearing gloves when there's not the ability to wash hands or use hand sanitizers. Next slide. And then we just basically have asked our industrial hygienists here to think about and looking at the COVID hazard as it relates to work steps, and to work with their customers out there in the field to make sure that we are minimizing as much as possible that COVID-19 risk. Next slide. We are looking right now at ventilation. There's been a lot of information that's come out in the last month or so. Our DOE, Department of Energy, has actually come up with some suggestions, requirements, and recommendations. So we're looking at all of these things as well, looking at our room air changes per hour, seeing if we can do additional measurements. We have fast systems in several of our buildings, and then looking at those buildings and creating that list for acceptable COVID occupancy, and then giving guidance on bathrooms, fans and space heaters, and portable air cleaners. Next slide. The verbal screening and temperature check protocol, I think everybody is familiar with. We ask the similar questions to self-assessment, and we use a non-contact thermometer for those instances. Next slide. So we have had some challenges with obtaining face masks or coverings PPE, and I know everybody is aware of these, so I'll just kind of put this out there. We actually started, just as an aside, using some New Mexico distilleries and other non-standard manufacturers to give us hand sanitizer and ethanol or isopropanol when it was so hard to obtain. We are still dealing with the availability of N95 and other necessary PPE. And so this is a constant issue for us. It's getting better, but the supply chain is still an issue for us. Next slide. Okay, I'm going to let Dr. P talk to this when she talks about how we do contact tracing. So I'm going to go next slide, please. So we do have a decision tree for cleaning and disinfecting workplaces. Next slide. It includes whether if we have a confirmed COVID-19 positive case, we make decisions based on that. And we are using the 7 days, which is probably very conservative, but we are using that from the CDC guidance. Next slide. If we have a test pending or it's recommended, we pretty much follow the same requirements that we do for a positive. And then, yeah, go ahead to D3. Next slide. Then if it's asymptomatic, we do case by case. Next slide. So we do a lot of case by case considerations, deciding whether to clean or not. These are some of the things that we look at when we are deciding to clean. Next slide. And I am ready for you, Sara.
Okay, thanks, Dina. So one of the things that I really think is a system that employers can facilitate is case containment. And a key part of that is identifying the cases. So we use our testing program and our daily self-assessment and our field health checks to identify cases. And then we use contact tracing to identify those people who are at risk of spreading COVID throughout the workforce, and then isolating them until we know it's safe for them to return. We have all the folks that are doing contact tracing trained by the Johns Hopkins University training program. Next slide. So we use a form called the line of inquiry form, and on another slide I'll talk a little bit about the information that we asked for on there. And then we also have a notification checklist, which is really key because I'm sure you're all aware that communication is a really important part of trying to manage perceptions across the workforce. And if we miss a piece on the notifications, then we have a lot of people calling with concerns and questions and feeling that we aren't addressing their safety appropriately. Next slide. So when we get a case, generally it comes through our hotline, and the hotline operator will complete the line of inquiry, provide the employee with instructions, and then initiate the notification tree. Our incident response commander, who's part of our emergency management organization, is the one that really starts then facilitating both facility mitigations and contact tracing. So they will work with the biosafety officer or Dina to really look at access control. Do we barricade? Do we clean? What do we need to do? And they'll also work with some of the facility reps to make sure that we have communications going out. And then if we have special situations like classified areas or people that require escorting, they also help coordinate that. They also then coordinate with the medical director to see who really falls under the close contact definition, who should be isolated, what guidance should we provide to people, and then also on case management, so tracking those people on isolation, tracking our positive cases, and then providing guidance for concerned family members and people like that. Next slide. So these are some of the questions we ask on our line of inquiry form. It really is designed to obtain information that helps us assess work-relatedness of the case. And then, are there other people that we need to be concerned about that could be close contacts and spreading the infection in different parts of the laboratory? And then what do we actually need to do to go out and clean facilities to protect other people in the workforce? Next slide. So we are using our New Mexico Department of Health definition for close contact, which differs a little bit from CDC. So it's someone who has been within 6 feet with or without face coverings for greater, sorry, this slide says 10 minutes, and I forgot to correct it. We're actually using 3 minutes now. And we are using a return to work approach that's based on a time-based approach rather than a test-based approach, after benchmarking with other DOE sites and also in accordance with CDC and Department of Health guidance. Employees must be fever-free for 24 hours. We actually use 14 days out rather than 10 days out because we tend to be a little bit conservative, and their symptoms must be improving. Next slide. For people who are found to be close contacts of employees who have COVID-like symptoms, we ask them to isolate until we get their COVID test back. We have a great testing program here. Our bioscience folks actually get us test results back the next business day, which has really helped us minimize the operational impacts of isolating those close contacts of presumptive cases. In the event where the index case refuses to get tested, they have to isolate for 14 days as if they were a confirmed positive, and then we ask the close contacts to test 5 days after their last known exposure. We actually haven't had a case of that, knock on wood, for quite some time. So most of our workers have been really cooperative with coming in and getting tested. Next slide. So when I speak to our leadership, I really like to speak to the non-pharmaceutical interventions that we use to help mitigate this pandemic, and I like threes. So I use the 3 categories of infection control, distancing, and case containment. And I really try to emphasize that it's really our job as leaders to manage risk, and that's through systems and policies and providing resources, and also leading people. And leading people is what drives behavior, and behavior, what's important for infection control and distancing. We need people to wear their face coverings. We need people to wash their hands. We need people to avoid gatherings. And we need to provide the leadership that drives that behavior not only at work, but also at home, because your behavior in the community as well as your behavior at work are inextricably tied to each other and your risk for COVID-19. Next slide. So this slide talks about the different teamwork partnerships that we participated in. I think the biggest one that we've really had, other than between industrial hygiene and medical, is also emergency medicine and medical. We've really integrated nicely for our hotline and our case responses, but then also teaming with other stakeholders in the community as well. Next slide. We continue to reach out to learn about what's working well and what can be improved upon. We did a learning team based on why employees are coming to work sick. We continue to look at evidence. Dina and I are great. You know, have you seen this article? Have you seen this article? We need to work on facilities. We need to work on this. So it's really been nice, and we continue to try and refine our processes moving forward. Next slide. We think that communication is really key. At the beginning of the pandemic, Dina and I were red carpet stars. We had multiple safety videos and communication videos for our folks, but really trying to communicate and drive home, again, that safe behavior through WebExes, participating in our worker environment safety and security teams, safety teams, but also doing one-on-one encounters whenever we can. Next slide. We all know that managing mental health and behavioral health through this pandemic is key, so we offer resources to our employees. Next slide. And then, as I mentioned, our worker environmental safety and security teams, or our WESST teams, have really been key in partnering with us to get communications out. And then the next slides I'll go through pretty quickly. They're examples of some of the signs and communications that we've put out. We've really tried to focus on a theme that you can see from the COVID Hub as well as the WESST Communications. Next slide. So these are some of the signs that we have available. Next slide. Next slide. Okay, and this is my last slide. And I talked about managing risk and leading people. And what I really wanted to leave off with is how important it is for industrial hygiene and medical to speak as one voice to the senior leaders so that we can be effective in protecting our workers, trying to create those systems and processes which support their health, well-being, and safety, and then also leading to drive responsible and safe behavior that protects all of us. And that's it.
Okay, this is Larry Sloan, and I'm going to talk briefly about this slide. AIHA, like many other organizations, has developed a family of resources that address the coronavirus and COVID. And so there's two main portals, and I'll put the URLs in the chat box when I'm finished here. The first is our COVID Resource Center in the left-hand side of the screen, and we propped that up back at the beginning of March. And that contains a variety of resources from government agencies, federal level, as well as AIHA resources and other allied organizations. And that includes a variety of guidance documents that AIHA subject matter experts have developed. So for example, we have guidance documents on cleaning and disinfection, use of UV disinfection, engineering controls, PPE considerations, and the like. The other family of products is something called Back to Work Safely, which is a library of documents that were developed over the last several months, and they're organized by industry sector. And we have a total of 26 of these Back to Work Safely guidance documents, ranging from restaurants to general office buildings to public spaces. Each of the guidance documents is configured from the perspective of what do I need to be doing as the employer, what do I need to be doing as an employee, and if I'm a member of the general public that's visiting a particular establishment, what should I be doing? So I will put the URLs for both of these websites in the chat box, and then I will turn it back over to Heather. Thank you.
Thank you, Dr. Pasqualoni, Dina, and Larry. I am going to turn it over to Dr. Leibu now. Dr. Leibu, you might be muted.
Yes, and in conclusion, hi, thank you so much for giving me the opportunity to speak today. Dr. Guzek and I are going to move to the next level to try and frame the prior presentation in terms of a common language that we share between industrial hygienists as well as occupational medicine professionals. And this slide that I'm showing now is the single most important slide for our presentation, and it's the utilization of the healthcare hierarchy, with the most effective control measures being listed at the top and the least effective being listed at the bottom. So I like the next slide, please, because we're going to be talking first about elimination. So Gretchen and I, Dr. Guzek and I, both work for large hospital systems. And when we're trying to control COVID-19 as well as other diseases, we're looking at ways to first and foremost eliminate the threat. So one of the ways that we are doing that is through screening of visitors and employees, screening at entrances, doing screenings prior to patient appointments in occupational medicine, doing it in the outpatient practices, pre-appointment screening for all patients that are coming in. And we also do pre-work screening on a daily basis and temperature checks when employees come into work. There are other measures. We use testing, we use quarantine, and we do have travel restrictions. We have a policy that minimizes all non-essential business travel, and we discourage employees from traveling to locations that are at high risk. In New Jersey, we have a list of states that are considered high risk, for which they're asking the non-healthcare professionals, people traveling to those areas who are not healthcare professionals, that they should quarantine for 14 days when they return. The last time that I checked 2 days ago, there were 43 states on that list. So essentially, we're all kind of managing in place. Dr. Guzek, did you have any further comments about measures from this slide that you're using for elimination? We do have one more slide after this talking about other elimination procedures.
Yes, thank you. I just wanted to mention that New York-Presbyterian hospital system is about 40 to 45,000 employees spread over seven campuses and 3 regional hospitals. So it's, and then of their affiliated doctors' offices. So it's been quite a challenge to manage all of these. There, at the larger institutions, there are only certain entrances that have been designated available either to visitors and patients versus employees. So that has allowed employees to realized that the importance of the pre-screening process in terms of the non-contact temperature checks, and then an app that we use for symptom checks, or if they're in the process of being tested for COVID, if they've returned to one of those restricted states. And it's been a evolving process, but we've reached some sort of new normal that people are more accustomed to, which is great. Testing is available at different campuses. We have divided the areas into those with symptoms and no symptoms to facilitate ease of use and comfort for the employees. Testing is not mandatory at our institution, but it is available, both the PCR and serology, and it's also not only for the hospital employees proper, but university affiliates, contractors, anyone who might be in and or associated with a medical center or affiliated doctor's offices. The quarantine period does follow, we do follow New York State guidelines. Initially, back in February, there was a 3-tier risk, very complicated system and furloughing, and that turned out to be very difficult to manage and to have employees be out of work since they were needed in the hospital. So that transitioned to people working if even exposed, but that then transitioned again to once the numbers decreased in terms of overall incidence of COVID, that we are furloughing employees who have been exposed either at work or in the community for the 14-day quarantine, and that a negative test result does not affect that. A positive result might change their isolation period, but a negative test result does not change that at this time. And for the travel restriction, just to reiterate, has also been evolving, but we follow the New York State guidelines and then the governor executive orders for that, and try to communicate all of this through a hotline that we do have available for employees. There is a public hotline that's available for patients and visitors, but we established a hotline that has been staffed by initially people who were redeployed from different outpatient settings that had been closed during the height of the pandemic. And so that has been extremely helpful for the employees who have questions about their symptoms, potential exposure, travel, many concerns.
Okay, one other thing I wanted to add, at Atlantic Health System, we also have a hotline. We use that hotline to screen all of our employees, anybody who was exposed at work or at home, anybody who has any symptoms, anybody who requires testing, and anybody who needs to be cleared to return to work. It's all done through our hotline and through our departments to make sure that we're not returning people back too soon, and we're capturing those who might be at highest risk for being some of the asymptomatic people who may actually be positive and not know that they may be spreading COVID to others. One of the biggest challenges we're finding is that people, when they're eating, are not maintaining 6 feet from one another. And oftentimes, even when they're out in their communities, they may be visiting with friends. Now that restrictions had been lifted, now we're starting to see an increase again. So things are starting to tighten down, but people were traveling to weddings and parties and spending time with friends at much closer distances than they had with the initial wave, and they're exposing themselves to each other. And then when they're coming to work, they find out, they may or may not know that people that they were with out in the community have tested positive, and they'll be eating lunch with others at work and not maintaining appropriate distances, and potentially infecting people when they don't know that they themselves have become positive for COVID. So that's one of the many challenges that we're all facing. Next slide, please. On other elimination practices are infection prevention practices. We have an extensive list of infection prevention policies in place. We have a COVID Central website where people can go to see all the policies and procedures to protect oneself from COVID, as well as other policies and procedures regarding work practices. I mentioned before about the travel restriction and reduction, and the last elimination strategy is vaccination. We all know there's a race for the vaccine. Right now there are 3 vaccines in the running that look like that one of the 3 or all of them will be coming out possibly in the near future. One is Moderna, from Moderna, the other is from Pfizer. Those are both mRNA vaccines. They require cold storage, like sub-zero storage, and require special refrigerators, and there's a whole work practice that has to be done in terms of transport and storage reconstitution of these vaccines. And there's another vaccine from AstraZeneca, which is an adenovirus vaccine that may be coming out. So there'll be more to come on that. There's a strategy that the government has for deploying these vaccines to select sites, and there are various planning groups now that are working on how these vaccines will be deployed and who will be getting the vaccine first. Healthcare workers are in the first tier, as well as people that are considered vulnerable if they get COVID. Gretchen, did you have anything to add?
I just wanted to say regarding masks and eye protection, it has been quite a culture change for most of the employees to embrace, and the masks have been more used. However, we still have incidences where people are not wearing masks if they've been in an office but close to someone else. And then eye protection also has been challenging to reiterate that it should be used at every patient encounter to decrease the risk of exposure.
One of the challenges that we are finding with eye protection is that there are patients coming in who it's not clear that they are positive for COVID. They may not be symptomatic. They may not even be positive initially when they come in and they're tested, and they may develop symptoms or test positive later. So we require face shields for all aerosol generating procedures. And we're also working on processes to minimize aerosol generating procedures, trying to eliminate the use of nebulizer treatments where possible and substitute with MDIs, as well as trying to do all nebulizing treatments or aerosol generating procedures in single patient rooms wherever possible. Some of our facilities don't have single patient rooms. Next slide, please. Substitution is another control measure that we use. Telemedicine has certainly taken a huge step forward. We're all talking about how telemedicine can be used in healthcare, and trying to institute it, and COVID-19 has helped that to move forward with lightning speed. Telemedicine, it has been, during the pandemic, had been utilized by most ambulatory practices wherever possible. And we also utilize telemedicine in occupational medicine. I did mention the other thing on the slide about MDIs for nebulizer treatments. So that's just another form of substitution that we have started to use. Gretchen, is there anything about substitution that you wanted to comment on?
Just to reinforce that the telemedicine field has really opened up to many of the specialties that would have been not able to function at all when the physical offices were closed. So that's been a very big help for both the provider side and the patient side, and also the internal medicine component or primary care was utilized a lot because employees, some of them don't have primary care providers. So even when we saw them, it was challenging for them to embrace that. But this has been very helpful so that they're able to get care, be evaluated, be followed, and that's been a very, very good benefit for the employees.
Next slide, please. Engineering controls were touched on briefly in the earlier presentation. We look at ventilation, improving air exchanges in the room, HEPA filtration where possible. There are Xenex machines that are using UV light technology to disinfect rooms. There is something called an intubation box that initially was used by anesthesia for intubating patients to try and, it's a box that fits around the patient to try and isolate them while they're being intubated and potentially generating aerosols. But the CDC recently said that these boxes should not be used unless they're under negative pressure, because it's felt that they may actually increase exposure to aerosols from COVID as opposed to reducing them. So this is certainly engineering controls, and all of these measures are evolving over time. One important thing is to redesign break rooms and dining areas. As I said, this has been a constant challenge with people dining and not having masks on and sitting too close. So there have been all different kinds of measures taken by safety, by facilities, and the rest of the organization to try and remove chairs from tables, distance tables apart, put signage down, noting where 6 feet is, putting up plexiglass shields. This is a whole area that's a constant challenge. And use of single rooms where possible, as I briefly touched upon that when I talked about the nebulizing procedures. Gretchen, is there anything you'd like to add to this?
Just for the, when there was a very large increase in volume for both general medical care, but intensive care units required, the hospitals had to facilitate the construction of different areas or refabrication of different areas to accommodate those patients. And that was also done, we had outdoor tents even at different institutions for testing areas, which was very helpful. Maybe not the most routine thing, but it was really remarkable how quickly something could be constructed when the need arose. And we since then have disbanded that because the numbers have decreased, but it's just really interesting how everything evolved due to the necessity of the pure numbers of everybody needing care.
Next slide, please. I want to touch upon some of the administrative controls. As I mentioned before, we have numerous policies and procedures about personal protection, about travel, about work practices that all address COVID and other, of course, other infectious diseases. Now that we have flu season upon us, we've added these policies to our other infection control policies. We try and telecommute where possible. That at least during the first wave of the pandemic, a lot of the non-healthcare worker jobs, the office jobs, were done by telecommuting and or staggering people in the office. So some people would telecommute one week and they'd come into the office the next week to try and minimize the number of people and make sure that people were able to social distance. Staggering shifts and breaks so that there aren't too many people sharing the break room or the cafeterias is another administrative control. Aerosolizing procedure reduction, I mentioned before. Social distancing, as always, that's one of the most important measures we all can take. And other administrative controls would be isolation and reassignment of high-risk workers. We had a number of workers who have high-risk conditions. They may have different conditions that put them make them immunocompromised. And during the first wave of the pandemic, a lot of them were reassigned. So HR was very accommodating, and it was took a whole department to work on reassignment of high-risk workers and redeployment of workers from units that had decreased activity because patients weren't coming to the hospital at the height of the pandemic unless they were really, really sick. So those are some of the administrative controls that I wanted to mention. Gretchen, do you have anything else that you wanted to talk about?
I just wanted to mention for our leadership, they did communicate changes to staff through daily video briefings, which I think everybody found very helpful when things were changing so rapidly. And the accommodations process has been particularly challenging regarding the unknowns about the risk of exposure, contagion, and severe illness for employees. I feel that now staff are more comfortable with the current state of the safety measures and personal protective equipment available that can be reassuring for their safety while working in their roles.
Okay, next slide. PPE, that I'm not going to go into too much detail about this, just to say that we all know that there were major challenges with getting appropriate protective equipment during the first wave, and strategic sourcing had to get creative. In New Jersey, we had other institutions that banded together and tried to put together the healthcare consortiums that could help to leverage our ordering and try and get supplies as quickly as possible. Next slide, please. Gretchen, did you want to comment about this slide?
Sure. This was just an article in JAMA in May regarding all the different components of PPE conservation and management. So I've just found it just a quick overview that it's very complex. There's many different parts, and it's not just a simple, here's a mask, wear it. There's a lot involved when we're talking about population dynamics and supply.
And thank you very much. Last slide. This, in dealing with supply chain issues, I just wanted everybody to be aware that there is on the CDC website a burn calculator that helps people to determine how much PPE they will need in a particular shift, a week, so that they are able to try and anticipate what their needs are. Whether or not they're going to be able to get all the protective equipment they need is a whole other issue, but that's one of the headaches that poor strategic sourcing had to deal with during this pandemic. And as the COVID wave 2 starts to pick up, they're going to possibly face these challenges again. I want to thank everybody for your attention, and I really appreciate all the work that everybody's doing to keep our workforce safe and healthy.
Thank you. Just a reminder to put your questions and answers in your questions, I'm sorry, in the Q&A box. We have had several questions and they've been answered, so you can click on the answered tab to see those answers. But I'm going to go ahead and read a question. This one is, it almost sounded like the slight deviation from CDC guidelines included that a significantly exposed individual could test their way out of a 14-day quarantine period. Did I hear that correctly? Could you confirm and clarify evidence supporting if I heard that process correctly?
So this is Dr. Pasqualoni. I can respond to that. So we actually, in the state of New Mexico, we have, because we're an essential business, we have an exemption for travel. And so what we did is, rather than just saying that all of our employees can go back to work without quarantining, we actually asked them to quarantine for 5 days and then test them. We know that the performance of the PCR is imperfect and there is a significant false negative rate. However, we have a lot of employees that we actually need in the workplace, and so we're trying to balance basically mission performance and mission support with employee health and safety. That goes the same for our close contacts. So we have some cases, because of the nature of the work we do, which requires people to work within 6 feet of each other. Say they're working in a glove box or working on one of our craft projects. We have some cases that can have up to 20 close contacts. And so trying to keep them out for the full 14 days has a significant impact on our mission. And so what we do for those select cases where there is potential for mission impact is we do allow them to test 5 days post-exposure and then allow them back onto the work site We also do tell them that just because we're allowing them back on the work site does not mean that they don't need to follow the New Mexico health guidelines when they're not at the workplace. So we don't tell them that this doesn't mean that they can go to the grocery store or go to parties or, go to restaurants or whatever may be open depending on what state the community's in.
We have another question. One of our workplaces purchased a number of 2-layer face coverings and is now deciding whether to switch to 3-layer face coverings. Any suggestions?
This is Dina. I can try and at least tell you what we're doing here. We're actually we've actually specified what defines a good face covering, and at least at this point we're saying at least 2 layers. So we take a lot of things into account when we're both procuring face masks or face coverings for ourselves, and when we are encouraging people who are planning to bring them from home. So we want to still make sure it's comfortable, that they can breathe through it. With a lot of our issues, and I know from the medical standpoint, this is the same. We wear safety glasses and a face mask or covering, so fogging is an issue. So we're doing our best to get things that fit as well as possible. And have at least those 2 layers, ideally 2 layers of different material. It's a constant, not battle, but it's a constant challenge for us to look at what's out there, what people may be bringing in, and what we can provide as a laboratory for our workers on site. So I hope that answers the question, at least for LANL.
Excellent. We have one question here. I'm not sure if this is something that you will be able to answer, but for employees who are furloughed when ill, what is the pay status? Furlough implies not paid. I'm sure that varies based on the organization.
This is Dr. Leibu. At our organization, patients who are out ill are paid. There are different regulations regarding pay, and at this point, any healthcare worker who has COVID is considered to have gotten it at work, so it would be work related unless there was other evidence that they had gotten COVID outside of work. For example, if they have a spouse who was positive, or they have a contact outside of work that was positive, or they traveled to a high-risk area and potentially there was a way to prove that they might have been exposed in another place than work. So most of the employees who are out of work are being paid through workers' comp.
Very good. All right, seeing no more questions and coming up on 1 o'clock, I'm going to move on and want to thank our faculty on behalf of ACOEM and AIHA leadership. Thank you so much for presenting today. As a reminder, today's webinar was recorded and a link will be sent to all registrants. To our attendees, thank you for attending. Have a great day and be safe.